and bleed out faster, right? Think about it, guys. Got a blood pressure that's low, barely hanging on because he's bleeding into his belly, bleeding into his chest. You're gonna give him epi, he's gonna bleed out faster because what does epi do? Increases heart rate and blood pressure. It's a short-term solution. You're gonna jack their heart rate up to like 150, blood pressure to 200, right? And then he's gonna bleed out. Make sense? All right. We're gonna change gears here and go on to medical cardiac arrest. I know we're running late on time. Stop me if you have a question, but we're gonna kind of be cruising along here, okay? The main thing to remember, get on the chest, stay on the chest, minimize interruptions, and defib early and often, okay? That's this in a nutshell. But why? So in a typical situation, somebody goes down. Now remember, this is medical cardiac arrest. We're switching gears here, so different. Somebody probably in VFib. So someone's gotta recognize it, call 911. We gotta get the dispatch, the turnout time. We're finally on the road at minute 4, and look what happens. Our coarse VFib starts to become finer, and then finally dissolved into asystole. Unfortunately, that's about the time we get to the patient. This is why our cardiac arrest survivals are bad. We don't get good outcomes because we get there too late to the party. We're already set up for failure. This is called the slope of death. Every minute that goes by in cardiac arrest, you lose your chance of survival by about 10%. So you do the math. 10 minutes without compressions, what's your chance of survival? Big fat 0, right? So we want to bend this slope. Notice I didn't say bend the curve. There's a lot of negative association with bend the curve. So we say bend the slope. So this is an underperforming CPR system. There's no telecommunicator CPR. Dispatch is not telling them to get on the chest and do compressions. So no compressions. We're finally on the road. We finally get to the scene after 1, 2, 3, 4 minutes. Pretty good response time if you ask me. We get to the patient and now we do CPR. And look, we're fighting for a measly 10% survival rate in a underperforming system. Now let's look at a better performing system. We do a delay in TCPR, but we finally get TCPR at minute 4. That's better than nothing. And then we get on scene, and now look, our survival rate bumped up to 30%. All right, let's look at a high performance or best practice. Rapid dispatch, as soon as we ask 2 questions. Is the patient conscious? No. Are they responding to you? Are they breathing normally? No. Put your hands on the chest. I'm gonna walk you through CPR. What's the worst that's gonna happen? Patient's gonna wake up and say, get off me, what are you doing, right? Or they're gonna get the care that they need and we're not going to go down the slope of death. So TCPR at minute 2, man, that's impressive. That's really good. We're saving life here, right? We get on scene, now we do high performance CPR and we'll talk about what that means. And then we defibrillate, and now we're looking at 50% survival rate. So we went from 10% to 50% with just a few small changes. Pretty good. All right, so this is interesting. So when we looked at CPR performance, we asked patients, or actually paramedics and EMTs, what do you think you do and what do you actually do when we do compressions? And what we found is that duty cycle, adequate compression depth, complete recoil, and hand placement accuracy we're not as good as we thought we were. So we're really bad at chest recoil. We're leaning into the patient. We need to allow for full chest recoil. The only thing we actually did better than we expected on was placement. But you can see all these other ones, we're not as good. This is why we gotta practice this. And next month, we'll come back with a high performance CPR mannequin, and it'll actually check every single compression, and you'll see, are you getting complete recoil? Are you getting the proper rate? And we're gonna use a metronome so we can cheat and stay on the metronome and stay between that 100 to 120 beats per minute. All right. Every time you stop compressions, so this is a patient who's in asystole, we're gonna do compressions. This is the pressure in the aorta. That's what we want to perfuse the heart. So about the first 16 compressions or so, you're just doing them to try to prime the pump. You finally get to a point where you're actually perfusing the aorta, and then if you stop CPR, you just drop off the cliff here. This is why we minimize interruptions and compressions. Oh, let's just check the rhythm for a few more seconds. I can't really tell what it is. When we do that, we miss out on all the work that we put in to get up to that level. All right, anyway, this just means the earlier you defibrillate, the better the response. So get to the patient early when they're in a shockable rhythm. We don't wait for them to dissolve into asystole. When we do CPR before we shock, we get a better outcome. So this looked at shocking right away versus shocking after 3 minutes of CPR. And we found that those patients do better. Why? Because when we do CPR, we perfuse the heart, we get the ATP levels up, and then it's going to be more likely to respond to the shock. So doing CPR, because guys, what do we do, right? When we get on scene, check pulse, no pulse. Our next thing should be get on the chest, if it's a medical cardiac arrest, right? And then you're setting up the pads, right? So all those compressions are going to prime the pump and get it ready to receive a shock, and your shock is going to be more effective. Instead of, hey, get off the chest, we got to put these pads on. No. Compressions until you're ready to put those pads on. Coordinate. All right, and this is just about rate. Our optimal rate is this for these reasons. Depth, about 2 inches. Then this is the survival rate, depending on how deep you go. Too little, bad survival. If you go even deeper, here you actually get still a pretty good survival rate. But anyway. This is the peri-shock pause. So what is a peri-shock pause? Hold CPR, charging, everybody clear, you're clear, I'm clear, dog's clear, shock, right? It's too long, right? We want to stop CPR and instantly shock if we can. If you've got a Lucas device, do you need a pause? You don't, right? Because you can shock while the Lucas is going. Okay, so you check the rhythm, press play on the Lucas, shock delivered as soon as you're ready to give it. Make sense? Also, pre-charging the monitor helps, so that way you're ready to deliver the shock even before you check the rhythm. Of course, if it's asystole, you're not going to shock, and you just dump the charge on the monitor. And when we get the LifePak 15s or whatever we get, we can talk about how to do that. All right. If you're leaning on the chest and you're not allowing for full recoil, you get a worse outcome in both the brain and the coronary or heart perfusion. So it's really important to allow chest recoil. Have you guys ever been in a cardiac arrest? You brought the patient into the hospital and person who's bagging the patient, looks like they're pumping up the lifeboat on the Titanic, right? They're pumping away, right? Sometimes they did a study at Shock Trauma, a famous hospital out in Maryland, and they found that some of the RTs, these are the masters of airway, right? RT, respiratory therapists, they were doing rates of like 40 and 50 breaths per minute. That is way too much. You're going to increase the pressure in the chest. You're not going to allow for blood to come back into the heart, and you're going to get a worse outcome. Hyperventilation decreases survival because it doesn't allow the blood to get back into the heart because you have too much pressure in the chest. So remember, you only need 1 breath every 6 seconds, or about 10 breaths per minute. All right, airway. Because we're not doing a lot of airway, I'm going to breeze through this even faster than we've been going. This is a really easy way to remember the rates for adults. It's 10 breaths per minute, child 20, infant 30. We're using small BVMs to give low tidal volumes to avoid hyperventilation. Why should we have the patient on capnography? What is AMR using? LifePak 15s? Okay, great. So why should you have a patient on capnography? It rules out a foreign body, right? So a lot of times we'll have a patient has an iGel in and we're ventilating. We're like, man, the capno is horrible, right? Well, it's probably because they have a foreign body in the airway. Maybe, just had a big steak sandwich or something. And so it's a good way to make sure that it's that the airway is not obstructed and also that the iGel is seated correctly in the pharynx. Another reason is that when you get ROSC, the end-tidal CO2 will bump up because the heart's now pumping and you're getting more circulation. And remember we talked about capnography, or end-tidal CO2 is a measure of perfusion. So when it's low, poor perfusion. When it bumps up, you're getting better perfusion. So when it bumps during cardiac arrest, so you're in the middle of your 2 minutes of CPR, and then you see your capno go from 10 up to 40, oh man, we probably got ROSC. So the next pulse check, you're gonna be looking for maybe they got a pulse back. And also, if it's low and it stays low, that patient's probably not gonna do well. All right, remember, anytime you're putting the pads on the patient, we're gonna create a heart sandwich. So make sure that we like anterior, posterior as our first placement. So we put the pad in the front, and then we put the pad between the shoulder blades in the back. That's the AP, or anterior posterior pad placement. Vector change, so in our system, after the 3 shocks, you have the option to do a vector change, which means just instead of anterior posterior, now you're doing anterior apex, the kind of more traditional location. And the reason we said to do anterior posterior is that once you put the Lucas device on, it's really hard to get to the back. Does that make sense? So that's why we do anterior posterior as the first placement, because that back one is really hard to get to once the patient's entrapped in the Lucas. Okay? But vector change means after 3 shocks, your 4th shock is going to be through a different set of pads, through a different location or different trajectory. That's what a vector is. It's a trajectory, right? DSD, what's DSD? Dual sequential defibrillation. So this is where you're having 2 sets of pads, 2 monitors, and you're shocking the patient at 360 and 360 at the same time, with a 1-second pause in between. So that's another way to do this. All right, when do you give epi? If it's a shockable rhythm, we want to give epi after the first 2 rounds of CPR, and the reason why is because epi puts patients into VFib. So we don't want to give it early in VFib. We want to give amio early, and then give epi later. Okay, so after your first 2 rounds of CPR, patient's still in a shockable rhythm, now you can give them epi. And hopefully you understand the logic there. Pre-charge the monitor, we kind of already talked about this. Here's what normally happens. All right guys, coming up on 2 minutes. Okay, check the pulse. Oh, it's in VFib. All right, charge the monitor. No CPR is being done. That's not, we could have done this a lot better, right? So, hey, Cap, give me a 15-second heads up before our pulse check. All right, coming down 15 seconds. Charge the monitor. And now we're ready to shock if they're in a shockable rhythm. So hold CPR, check rhythm. No pulse, VFib on the monitor, shock delivered, back on the chest. See how that's way more efficient? If somebody has hyperkalemia because we suspect they're end-stage renal disease, they're in cardiac arrest, you want to avoid amio because it basically locks up the heart and it doesn't allow it to pump. Bicarb really doesn't help in cardiac arrest. It actually makes them more acidotic, believe it or not. We won't get into the details right now. All right. It's possible. It can't help. Like DKA, sometimes we do it as a short-term solution, but it's really not a long-term plan. Metronome, when we get the life packs, we'll do training on it, and we'll show you guys how to turn on the metronome. It'll click. There's apps that you can get in the meantime, like Handtevi. Anyway, metronome. You just need something that will count between 100 and 120 beats per minute, and that way you can sync up with it and just follow. You never want to be off the chest for more than 10 seconds in medical cardiac arrest. This was a study they did out of Hilton Head Fire Department. Until 2013, they were doing hands-on CPR. They got Lucas, and they actually saw a reduction. So we were doing better with hands-on CPR. And some people would say, you know, the AHA just released, and they said that Lucas device doesn't improve outcomes. It also doesn't make it worse, by the way. And especially depending on your system, it does free up hands, and it is easier. As long as you're using it correctly, the Lucas isn't shifting, isn't it migrating down, then you're probably fine to continue to use the Lucas, and we still endorse using mechanical CPR devices like the Lucas. And a lot of our agencies had it, and they told us, you know, if you take our Lucas away, we're going to be really angry with you. So we let them keep it. All right, we can skip through this. The optimal number of people on scene, this study said was about 9. Sometimes we don't have that, but all right. This is really important. We're going to spend some time on this. So where does everybody go during a cardiac arrest? Well, the lead medic is always going to be on the patient's left side. And this kind of makes sense because on most ambulances, you're usually on that side of the patient when you're in the back of the ambulance, in the gurney, right? And you're going to put the cardiac monitor here. The monitor is going to be facing towards the patient's head so that the lead medic can see it. Your number 2 person is going to be the compressor on this side of the patient, the right side of the patient. The CPR device is going to be behind them, and once we're ready to deploy the Lucas device, we are on the same side as the compressor, okay? This has all been thought out and choreographed, and this is why we have spots for people so that when we're first on scene as the fire department and then AMR comes in, we know where everybody is standing because we have a position 1, 2, 3, and we know everybody's job. Have you guys ever watched F1 or NASCAR? How long does it take for them to change all 4 tires and fuel up the vehicle? Seconds. How long would it take me and Dr. Holland to change all those tires? And probably minutes or hours, depending on how familiar, right? Why are they so fast? Because everybody knows their job. There's no wasted motion. This is how we should be doing cardiac arrest. In fact, in a lot of our systems, our medics are so good when they bring them into the hospital, the ER nurses and docs take over, and then the wheels fall off the bus. And that patient that was doing better now gets worse. And this led to a lot of complaints from our EMS agency saying, hey, we're doing all this high-performance CPR that you guys taught us. We would take this patient in the ER, and they just mess everything up. So we started to train the nurses, and they got on board with this, and now our cardiac arrest in the ER is running more smoothly because we're using pit crew style CPR, okay? All right, termination and resuscitation. I told you we'd talk about this more. We'll talk about it here. So it's optional. Remember, if a patient has obvious signs of death, decapitation, lividity, incineration, prolonged submersion for more than an hour in water or some liquid, you don't have to call. You're not going to resuscitate that patient. You're not even going to start. Now, let's say you are resuscitating a patient. You're going to follow the checklist, which we'll go over in a minute. You do not have to call med control to terminate resuscitation in the field. You currently do, right?
No.
Oh, you still, oh, okay, that's pretty rare.
There's a breakdown of stuff that I have to follow. Mostly we call for CYA.
Okay, you can call, but remember, you don't have to. The other thing is that termination in the field, what's the goal of termination? Why do we terminate in the field? Because we're being mean to the patient?
I can give you the hospital answer.
Okay.
So we don't bring dead bodies to the hospital.
True. Yeah, it's really the essence of it, right? So remember, EMS is a resource. And like all resources, it has limitations, meaning it's not infinite. We don't have infinite number of ambulances, providers to respond, equipment. So we're only going to resuscitate the patients who have a decent chance of survival. We're not going to waste resources on patients who are never going to respond. So this is why we built this. So it's easy. 1, 2, 3 steps. If any of the following, you must transport. If we witness the cardiac arrest, we should probably transport. This guy was alive when we found him, and now he's dead. We should probably transport that patient, right? Everybody agree? If the patient is greater than 22 weeks pregnant, we should probably transport. Why? Because it could be eclampsia. We could deliver the baby. The baby may still be viable at 22 weeks. And then the ER doctor, OB/GYN, can decide to do what's called a perimortem C-section, or now known as a resuscitative hysterotomy. If the patient's hypothermic, we all have heard this saying, right? You're not dead until you're warm and dead, right? So below 86 degrees Fahrenheit, none of our medications or defibrillations work. We got to get them at least above 90 degrees before they will work. So if we can get a temperature on scene and they're really low, we can't call it if they're hypothermic. Make sense? So if you get any of these, you don't even need the rest of the checklist. You just say, hey, we're transporting. We're not going to be able to call this one in the field. All right, if they don't meet any of these criteria, you move on to step 2. You must check all of these. They must have an ET tube or a supraglottic airway, iGel, whatever you're using. What's AMR using? It's like a
AirQ.
AirQ. Okay, yeah, got it. All right. So that's fine, a supraglottic airway. You need to do at least 15 minutes of ACLS or PALS. If you get ROSC at any point, the clock restarts, another 15 minutes. But I'll tell you, we don't have this happen a lot because if they get ROSC once, most of those guys are getting transported. You don't want to be doing this for 15 minutes on, off, on scene, because that patient's probably viable. All right, if you've done all of these, and then you get on to step 3, you need to have at least asystole or slow PEA. And if that's the case, we can terminate. And you do not have to call medical control. But if it's a gray area, you're worried, just go ahead and call. If you have ultrasound, you can check for heart motion. Excuse me. All right. We're going to watch some of these videos about high performance CPR. This is kind of stuff that we're going to be learning. So we're just going to briefly go over this. Sorry, let me turn this up so you can actually hear it.
Okay, monitor's coming on. No pulse. Start CPR. Start CPR.
The metronome's on. He's syncing up with the metronome.
Ready?
They're communicating about when to put the pads, minimizing interruptions.
Ready? Yep.
Oh, sorry.
Okay. Alright, CPR's going, metronome's going. Perfect. So we're just waiting for more.
Cool. So you see where the lead medic was sitting. He's following the platform, the pit crew style, putting his monitor where it's supposed to go, and then they're all following the same kind of choreography.
Okay, monitor.
These are just things to also think about. We're going to cover this all in detail later, so I'm just going to breeze over this since we're nearly out of time. But I want you guys to see a whole resuscitation in real time. Oh, I'm sorry. This is the guys doing throwing the Lucas, okay? So when you put the Lucas device on, that can take a lot of time if you're not thinking about what to do in advance. So this is a good example about how long it should take to do the Lucas device. So watch how he grabs the arms,
4, 3,
counts down.
go.
It's pretty fast, right? Pretty good. You're not fumbling around. So we call that clamshelling, where you put one side of the Lucas is attached. Do we have Lucas here?
No.
AMR? Oh, okay. Well,
The only people that have a Lewis device is Burke, but they take it off before we transfer.
okay. All right. Well, we won't spend too much time on that then.
Alright. Turn the monitor on.
Timer set up for you.
Monitor's going.
So look at the placement here.
Start CPR.
He's on the patient's left. This is the lead medic. There's the monitor there. Compressions. They didn't waste any time. No pulse. Get on the chest. Communicating on when to place the.
One deploy.
They're going to do anterior, posterior to start.
Two is deployed. Alright, so get Capno ready for them when they get here. We don't have any information.
So help arrives.
Unwitnessed arrest. No information yet. We got CPR going, got pads on, got metronome going. So go ahead and get an IGL. Let's get access. Cap, you got time for us? I do have time. All right. IGL. 4 IGL plays. Capno's zeroing out. All right. Capno's good. Okay. There you go. All right. Got IV access. Let's try to get a blood sugar. Go through our H's and T's. Taking off beat. Okay.
Ventilating 10 times a minute,
All right.
metronome. And high flow oxygen.
You guys know we're at 45 cap?
We'll do.
All right.
And we're going to 2 minutes and then switch it to
Yep, ventilate. Ventilate. Ventilate.
Capno's at like 14.
Ventilate. Ventilate.
We don't have unwitnessed arrest.
There's a number of apps that have metronome and a timer, like a CPR app.
Pulse. Pre-charge the monitor. Monitor's charged, got a mechanical pulse.
Ventilate.
It's not chaotic,
Okay.
calm, controlled, no one's screaming,
Start
right?
CPR. All right, let's get the Lucas ready for deployment. That'll come from this side. Get 300 of the medium.
All right, so you guys get the idea. So next time we come back, we'll practice this. You'll get some feel on being a team lead, how to switch out. We won't practice the Lucas if we don't have it. And just getting an idea of how high performance CPR works and how smooth this can be, minimizing interruptions and compressions, working together, having a system. So it's cookie cutter. We do the cardiac arrest the same way every time. Some of our agencies, they do a mega code Monday. So if you're on a Monday shift, we're doing a mega code just like this. And we're going to practice this so that these skills don't degrade. And once we get on scene, you'll see your training kicks in and everybody just knows the spot they're going to go to because you've got the lead medic, you've got the compressor, and you say you're in the number 1 position, number 2, number 3. Even go into the call, you're pulling out your chart and you just say, hey, I'm number 1, you're going to be number 2, number 3, and then when other helps arrives, we'll have them fill in at the other positions. Communicating, right? Pre-charging the monitor, minimizing interruptions. These are the things that make a difference, and you get survivors. Okay? All right, guys, that's it. That's all I have for you. I know that's a lot. Don't feel overwhelmed. This is just a big overview. We're going to get into the details of how to train you guys. We're going to do additional training. But I thank you for your attention. Any questions at this point? New protocols will be released here pretty soon. We're doing the last finalization. We're going to be, Jimmy and I are going to be going through and talking about what we're going to leave in, what we're going to take out to kind of simplify. And like I said, we're going to start basic, make sure we're all at a certain level, and then we're going to add on to that as needed. Okay? All right. Thank you for your time, guys.
Send me your questions as they come up.